Good morning and welcome to the Neuroveda podcast for complex health. We feature guests who dive into the ancient and cutting edge understandings of health and disease. These conversations are about food, lifestyle, and medicine just as much as about nature, culture, and politics. I'm Jillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine, coming to you from our clinic, Neuroveda Health, in Seattle, Washington. And I have honestly one of my most favorite doctors ever, which I know I've told him this as well, but the way that David Rakel speaks about medicine and connection is so elemental to the core of healing. So I'll read you his bio and then we'll get started. Dr. David Rakel is professor and chair of the University of Wisconsin Department of Family Medicine and Community Health. Rakel joined DFMCH faculty in 2001. He founded the Integrative Health program, now known as the Osher Center for Integrative Health at University of Wisconsin-Madison, and received the Gold Foundation's Leonard Humanism in Medicine Award, the school's highest honor for excellence in compassion and care. His team worked with more than 50 clinical systems within the Veterans Health Administration, or the VA, to implement changes to make care more personalized, proactive, and patient-driven. An author of both academic and popular writings, one of Dr. Rakel's missions is to communicate medical information in a way that is accessible to people of all backgrounds. He's published 11 books, including the Textbook of Family Medicine, Current Therapy, and Integrative Medicine, as well as peer-reviewed research on the impact of measures such as mindfulness, meditation, and the power of the therapeutic encounter. His 2018 book, The Compassionate Connection, focuses on how compassionate relationships can influence health outcomes, and I would also just say global outcomes. And I think that's really where we are at in the world today here in June of 2025 is I think that compassionate relationships really have the potential to fix kind of everything that's wrong in the world. So we won't necessarily start there, but I want to say welcome, and we're so happy to have you.
Thank you, Jillian. It's good to be with you. Full disclaimer, we won't be able to solve the world's problems in this podcast, but we can talk about how we might do it, which is always fun.
Yes, very much so, very much so. So I want to start today. This podcast today is really just about good medicine and how it is rooted in the doctor-patient connection. Let's start with your study on the common cold, including the unexpected twist, which makes me cry nearly every time I hear it. So I'll just be over here weeping and you can tell your story if you don't mind.
Sure, you're referring to a study. The PI on that study was Bruce Barrett, and this was done in the around 2016, 2017, and we wanted to see whether it was the interaction between patient and clinician or an herb, echinacea, or nothing that had the biggest impact. And I was in charge of the relationship paper. And so with each patient had to have symptoms of a common cold, like a runny nose or a mild cough, within 48 hours of being randomized into three scenarios. One was a standard care doctor. That was really the bad doctor, but we couldn't get that through the IRB. But the standard is, what are you doing here? You got a common cold. Get out of my office. You're wasting my time. That was the impression we wanted to give. And then there was an enhanced doctor patient relationship. And that's where we really tried to stack the deck in favor of those non-specific factors that influence healing through human connection. And then the third was no doctor at all. And in what we found, we looked at objective and subjective measures. So the main subjective measure was the patient's perception of empathy in the clinician, in us. Did they see us as feeling their story and really being part of their experience? And then the other one was nasal neutrophils and interleukin 8. So these are the immune mediators that become activated with the common cold. And then we looked at the duration and severity of the common cold. Long story short, holding everything else consistent, thank God, the enhanced relationship had the biggest effect, not only on severity, but also duration. When patients perceived us as really good in empathy, it shortened the duration of the common cold by 1.11 days. And that's pretty good for the most common infectious disease on the planet. And what came in second place, always makes me giggle a little bit, was seeing no doctor at all. You're actually better off staying home and being licked by your kind dog than coming in
Uh-huh.
and seeing a standard burned out doctor who doesn't make you feel like you're truly being listened to. So that was a summary of those findings, and along with many other studies have shown that the ceremony that we create in dialogue with another human being is the container that really holds the secret sauce of how we facilitate positive change towards self-healing within complex systems. I love the title of your podcast because humans are complex, right? We've got this biopsychosocial spiritual uniqueness that we have to go into that lens of seeing that through the people we're trying to serve so we can better understand the plan and the strategy. The part that you're talking about makes you cry. There's a story within that. I can tell that if you like, but I'll pause there in case we have any questions.
No, that's great. Go for it. This is all yes, this is all exactly what, I wanted to talk about today.
Well, the story, as with most things that we learn from, is how we failed. And I failed this patient. And the inclusion criteria was 12 years old.
Mhm.
So, in order to be included in this study, you had to be at least 12 years old. And before we would pull the card for standard or enhanced doctor, we had a video camera so we could see the patient in the room. And in the room was this beautiful 12-year-old African American girl who was in her Sunday best. She had a beautiful little dress on, and she was sitting on the table with her hands folded, just beauty. It was just simply a beautiful human being. And when I went in to pull the Meninva envelope to tell me whether I was in standard or enhanced mode. And we had to take acting lessons for this, right? We had to take acting lessons. So when we drew the standard, we felt disconnect, right? How can I disconnect from this human being? When we pulled the enhanced card, how can I connect? How can I really blend into the dialogue between two human beings where we really form that trusting
Yeah.
relationship? So after seeing this beautiful 12-year-old, I was saying, "Oh, please be enhanced, please be enhanced, please be enhanced." And I drew the standard card. So I had to have that disconnect.
Mhm.
And the minute I walked in that door, I just felt this vortex of pull.
Yeah.
that that the universe wanted me to really connect, and she wanted to really connect, but I was a good scientist, and I blocked that beautiful force to bring two people together, and I disconnected, and, I was a good scientist,
Yeah.
and I went through the process, I asked all the right questions, and I could feel her wanting to connect with me because I could sense that she knew I needed more than she did. And at the end, we would ask every patient, "Do you have any questions?" And she said, "Yes. Do you have a family?" And so that was her way of trying to connect with me, realizing I needed something that she could offer.
Yeah.
And I was a good scientist, and I said, "I've got a wife and 3 kids. Any more questions?" And then I left. And I still feel that ache, that pain in my heart, right in here, just remembering that. Not only how did me being a good scientist affect her, how did it influence her perception of tall white doctors in her future? And what harm did I cause? Not
Mhm.
only to her, but we also found that when we pulled that standard card as clinicians, it hurt. We hated it. It added to our burnout when
Mhm.
we block this humanistic gift
Mhm.
to really connect in a deeper way with one another. So I wrote about that. I can't remember which patient was, but the title of the paper is number 529 standard. And it tells that story. It's those failures. To this day, I wish I would have broken the protocol. Thank you for asking. That's so kind. I've got a wife and 3 kids, and my oldest daughter reminds me of you. And then how do you always allow that connection, that therapeutic connection to unfold? Because that really determines what we're seeing in this business of medicine is more towards transactional care. But
Yeah.
what humans are going to need more of is transformational care. And that transformational care allows 2 humans to go deeper into meaning together.
Yeah, exactly. I love that story. I tell that story a lot because I think that And I know I keep going back to this like nutshell of connection between two people and then this global situation that we have. But I am absolutely convinced that if our people on a global stage, if these actors in this global theater, where we have conflict breaking out across the world, if we had more connection, more human connection, that we would have greater capacity and we would have less disaster. And it's not to say yes, our climate and resource allocation, there's components around that as well. But I also believe that that is due to this lack of this fundamental core of what you're talking about and what is like exemplified in this one story, in this one situation. We can all feel kind of how you went in, what you want, what you felt in your spirit, what you felt was appropriate for the future of humanity. I know I keep going big, but I
That's
can't
good. Let's go big.
I know, because I think that, life is made up of a series of moments. And when we flip what our questions are and when we flip what our priorities are, we get to different outcomes. My dad used to say Will Rogers had a quote like it doesn't matter what road you're on. Wait, it doesn't matter where you're going if you're on the wrong road. And so I think the questions that we ask in medicine about like curing a disease are different than we need to be asking about healing a person. And I know that, from the studies that I've done over, these last however many years I've been in medicine, but I kind of came of age, my nurse practitioner training was 2008 to 2011. And so there were a lot of changes happening in healthcare with Obamacare at that time. And it was we have some really strong public health characters at University of Washington. And so I was reading all these papers, how we went from this patriarchal, like doctor knows best, to this patient-centered care and how that really ballooned the opiate, crisis in a lot of ways. Because patients would be like, "I'm hurting," and we would be like, "Aye, aye, captain, here's more pills." And that how that really needed to make this change to relationship-centered care, and it is the reason that I feel like I can actually be in medicine is because it is a co-healing that happens, and so we are co-destroying our clinicians and our patients when we set up a system in which we are not allowed to connect. And so and
Yes.
and I remember there's, Steve do you know Stephen Bizruchka? Dr.
No.
Stephen so he wrote a book called Inequality Kills Us All. He's fantastic clinician. He's now retired. He's in the public health department, but he came to speak in my public health course in 2009. And I apologize to my listeners if I've told this story before and now you're bored, but he came to speak in 2009 and he talked about how social and political factors were like 80% of outcomes,
Mhm.
permanent of health
Sure.
outcomes. There's nothing that'll destroy your health faster than poverty and racism. So, and it's not racism. It's not race that's the problem. Even though we often say like African Americans have shorter lives or African Americans have these particular health outcomes for asthma or COPD or whatever it is racism that's the problem. It is not a problem of African Americans or the race of their health. It is the problem of racism's impact on people.
Yeah.
And so he talked about social and political factors, and I thought, wow, if I really want to help people, I have to go into policy. Like I have to be like a lawyer or like a government person if I really want to help the most people. And I followed him like a little puppy back to his office. There's a few clinicians in this world that I just feel like have mentored me, even though they may or may not have known it. You are one, Bob Navio and the mitochondrial work, and Stephen Bizruchka. And so some of the few. So I followed him back to his office. I was like, I have to know more of what you're talking about. I don't understand. He told me about a book called The Spirit Level, which is now 15 years old, which I know you know. And they now have like a website that's like The Spirit Level at 15 years. And it's not, when I first heard the title, I thought, oh, this is some woo-woo bullshit. And it is not. It is a super like kind of boring textbook by two British economists talking about how when there's greater wealth inequality, all of our health suffers. And I just gave it to Callie Means. I just sent that book to Callie Means, who's the brother of Casey Means, who's our new Surgeon General, who has been described as a wellness influencer. And I met Callie and said, you have to know this really important thing that social and political factors and wealth inequality determines so much of health outcome. If we're going to change health in the US, we really have to change policy.
Mhm.
So the moral of the story is that I went out to Stephen Bizruchka's office and I spent 3 weeks in nurse practitioner school going, "Oh my god, I have to quit this and I have to go into policy if I wanna help people." And then I realized that what my skill set was really around was connecting with people, and that and that I was not gonna be a good policy person, I was gonna be a good clinician. I was gonna be a good doctor of nursing practice. I was That was the skill that I really had that I really needed to kind of, like, move my life around, and so, I finished my program, and now I've been in practice all these years. It is the patient-doctor connection is so elemental to our health outcomes and to what we do in the world and to how we feel loved and how we heal. So, anyway, that's the long and short of why I love that story so much.
Well, listening to your beautiful comments, I mean, there's a number of areas that just sparked ideas. The first is policy. You're right. That's why it's so important that our political leaders have good insight into this.
Mhm.
No, I don't want to say absolutes, but it's rare that a political figure will make investments to prevent disease 20 years from now because they won't get reelected. So most
Yeah.
political characters want in a more immediate, well, I voted for this and it's happening to your life right now, which makes sense. But
Yeah.
really, health is about the long conversation. And so we need to do this differently. We need to have different intent. That my favorite mantras is that to which we give attention grows. If we had salutogenic intent, salute health, genesis, origins of health, we would do things dramatically different.
Mhm.
And you're seeing in the dichotomy of belonging and othering, if you want to create political control, create fear of the other, and let the population know you have the answer to that fear. And we
Mm.
kind of do that in healthcare. The fear is, well, what if I have a cancer? Or what if I have this other thing that will help, that will not help, but I might lose my autonomy, I might lose control over my normal life. And when that becomes the product of capitalism, how do we make money? We make money by ordering more things, prescribing more things. When that is the economic model that drives our work, as you said, it's hard to be a good clinician in a dysfunctional model. It's
Yeah.
hard to be a good doctor, nurse practitioner, APP, et cetera, nurse, anybody in a system that currently pays almost $5 trillion for the worst health outcomes compared to all the other industrialized countries. So we have to do things differently. And this is a good example. You know this better than I, but social media has added to this. When I post something on social media, it feeds me things to reinforce my belief system, which reduces my cognitive diversity to see things in a different light. And when we talk about salutogenic intent, we talk about healing between two people, I have to fill my gaps
Mhm.
with the other person's wisdom. So actually, I can't do this job until I think differently, or if I think outside of my own lenses and I sit with compassion and put Jillian's lenses on, understand how she sees her world, what she needs to be healthy, no matter what that is. And then I put my lenses back on in service of her best outcome. So that's a completely different model than what we have now. It probably won't change in my career, but hopefully we'll set it up for a better outcome. And I think value-based care, really understanding how we can add margin to what we do by keeping people healthy and out of the hospital and on less polypharmacy, that's the economic model of the future. But we've been talking about that for 25 years. And whenever a health system suffers, it always turns to its highest, most profitable procedures. That is always the strategy, which helps us continue this dysfunctional model of care. Some policy member has to help us look 20 years down the road if we're really going to change a system that's set up for othering, where it needs to be more about belonging for every human being.
And so I know I have a lot of thoughts in my head. Well, and we talk about we have a healthcare system that is fee for service. So to look at the dichotomy between value based care or fee for service, can you talk a little bit about how those different structures are set up or could be set up?
Sure, and I think we can have a blended model. Actually, some of the best healthcare systems in the world have a blended model. So it's
Mhm.
not one or the other. So if I'm a surgeon, it's probably best that I get paid on an RVU systems. The more procedures I've been trained to do, that is equivalent to my salary or payment structure. But if
Mhm.
I'm an interprofessional of clinicians out in a community, then I have to do some population health. I got to understand what are the most common diseases in my community. I need to first ask my community what they need from me instead of me just projecting my science inappropriately, because a lot of harm can happen if I just think I know what you need and then give it to you. And so it's a whole different salutogenic science, right? So that needs more of a capitated model where if I keep that population healthy and more resilient, then I make money that way because that is the financial intent. And I'm getting a little cynical as I get older, but if you want to change a system, change what you pay for. And we are slow to do that. But we're starting. And that's why Oak Street Medical, a company that focuses on keeping elderly healthy and out of a hospital, was sold for I don't know, $10.3 billion. So the market is starting to shift because it's unsustainable, the find it, fix it throughput model of healthcare, which is mainly RVU based. Doesn't work well for primary care. It works a little bit. So we still pay our faculty a percentage for RVU, but most of it is being present in the clinic to manage a population of patients through trusting relationships with continuity of care.
And so an RVU is relative value unit. So the idea is that clinicians make some sort of base salary, but that then the more patients you see, you get a little bit of each of those visits. There's an RVU value assignment for each visit. So it's an incentive for clinicians to see more patients because that
Yeah.
is going to bring more money into the system overall.
Yeah, it's more of a widget approach. Again, not a bad thing, but if I get paid and I have to put my kids through college via widget approach, I'm gonna, hey, I need to see you in 2 weeks again just to make sure that everything's going okay. Versus, hey, maybe you can see my health coach who's really skilled in developing trusting relationships, but pragmatically, their salary is more sustainable than mine. And so, how do we direct the patient to the best relationship possible for their best outcome? And that's shifting the work of the primary care clinician, which is another challenge we could talk about. But now I used to steal from the earache to give to the depression. Now I rarely see earaches anymore. It's patients with multiple medications, multiple interactive diseases that we have to organize and work through.
Yeah. Wild. Okay, so I'm trying to think about where do I wanna go next, just because there's I yeah. So when I was in the RVU model, it was a real struggle with functional medicine patients, these really complex patients, and by the end of my nearly 7 years in primary care doing Ayurveda and functional medicine in primary care, I had received 2 letters from insurance companies with little graphs showing me that I was doing time-based billing, and according to my peers, like, in comparison to my peers, I was doing much higher time-based billing, and if I didn't, come to my senses and correct my behavior, there would be an audit of my charts and potential payback necessary. And this was, I just thought it was so interesting that my charting was fine. I was seeing patients with multiple illnesses or complex things like myalgic encephalomyelitis, chronic fatigue syndrome. So it was very bedbound patients, with multiple comorbidities. So it was not that I was scared that my charting wouldn't support it. It was just interesting that I was not lauded for supporting the 5% of patients that take up, the 60% of resources in healthcare. It was at some level threatened for doing that work, but taking more time to do it.
Yeah. Yeah, that's a challenge. We need both, right? We need the way we've tried to organize that here is that we create a half day for people to go deeper. And this is I've learned so much from my failures. We created a SOS session, a salutogenic oriented session where the intent was to do what you did in those longer appointments. There's some patients we just got to go deeper. We got to listen to their story. It takes time. And then we have to organize all those things. And this is what Ayurveda teaches, what functional medicine teaches, all good medicine teaches. At some point, you have to go deeper into understanding the complexity and the antecedents of that story. And we carved out a 40-minute visit because that was a 99215 code, so we could maximize the time code. And we tried to put that in a period within a busy primary care office where they could really go deeper into the story. The reason it failed was other demands always bled into that time. So people had to double book a patient who had to be seen that day. And this is the most sad thing. Our clinicians didn't feel comfortable doing that, right? I mean, these are people who go into primary care, but they felt, how do I do that? I've gotten so used to this quick model that we almost had to retrain that presence, that salutogenic approach. So that was a opportunity to learn. But I think we can do both. One of the economic models that we're seeing working in primary care is a direct to primary care model. So this is direct to primary care means that you can use a health savings account or some other tax deferred money to give a clinic a per member per month payment. So let's say it's $50 and you have a number of patients who you are responsible for. That's your population that you get a per member per month to support your team to support that population, and then you carve your profit out of that. The reason that has promise is you're removing a lot of middle people. You're having a high deductible insurance, so the premiums go down so you can afford to direct money to the direct to primary care. So it's a much more, let's give money where money matters and is needed most to manage this population, which that's why that's growing so much. The
Mhm.
challenge there is the average population that we have for our clinicians in primary care is 1,800 patients. So that's kind of the benchmark. But that's a team. We have pharmacists, we have nurses, we have mental health providers, and that's 1,800. The average for a direct to primary care clinic is about 600. So you can make a pretty good living if someone's paying you a monthly amount with 600 patients. So what does that mean? Those 600 patients are really lucky, number one,
Yeah.
because they get more of this more personalized care with someone they know and trust. But what if the whole country went from an 1,800 panel to a 600 panel? What would that do to our current challenges in access? So I think we can find a blended way to do this where we can
Uh-huh.
expand the panel that we can manage through resourcing multiple professionals. So we get out of the old way of the clinician bottleneck appointment that you can't get in to see the system until you make an appointment with yourself or myself, because that could be 6 months from now,
Yeah.
to where we have access to a team of professionals. Remember Cheers when Norm would come in and everybody would say, no, that's the model we want. So the psychologists, the front office staff, the nutritionist, everybody knows your name. And then we get you in to see the most appropriate person for your situation. So if I'm a little depressed, before someone sees me, where often I'll probably prescribe some drugs, maybe they see the behaviorist to really understand the context of their suffering. And maybe if we start there, we'll need less drugs to influence the hormones in the brain down the road. So that's where we're going to evolve. And then we're going to bring AI into this, and AI might be part of that team. So we really use AI to its fullest so we can really protect time for humans to do more human things, for humans to be more human. And I truly believe AI is advancing so quickly, but people are going to be aching for that human connection. There's something about this space, we call it liminality, that place of suspension, Jillian, when you and your patient are in that room together. You're suspended in this potential opportunity where that dialogue results in you falling off into a healthier decision-making process that you both believe will result in an improved outcome for the current situation. And that's what we need humans to be doing. And then
Yes.
AI can do all the, hey, you need a colonoscopy. I don't care if I ever talk about what immunizations you need again. That's something a computer can do. And the
Yep.
computer can do it very well. And I don't have to memorize all those different protocols that change every year. But if someone is really against immunization, then we have dialogue, we have shared decision making, and we understand their belief system so we can find the best way for them in their context.
Perfect. Perfect. So, can you tell us a little bit about the projects that have unfolded at the VA? Because the VA really is an encapsulation. I mean, that where it's, you really are looking 20 years down the road. You're able to
Yeah.
kind of do some of that modeling. And so, how did that project come about and what was involved in that and where is it now?
Oh, it's evolved so much. It was, when I did my fellowship, Tracy Gaudet was our fellowship director at the University of Arizona. And then she went to Duke, and then when she went to the VA, and she started this whole health program that was meant to change the conversation. So the conversation was changed from what's wrong with you to what's right with you, or uh, asking some deeper questions that would influence human behavior the most, like what do you want your health for? That's my favorite that we talked about a lot, because when you go into meaning, it's more likely to influence how you behave. who you forgive, what food you eat, how much you exercise. And health is much more about what you do than what you take by far. And if we look at the evidence of the main determinants of health, as you said, most of it's outside the health system. It's creating access to good, healthy food, having bike and running trails that help with transportation within a crowded urban environment. But how do we get people to use those, right? If we not only have to build them and create an environment that makes healthy choices the easiest, but we also have to encourage people to do that. So Tracy asked myself and the University of Wisconsin to go in and help train a little Norway. And that's what I loved about it. Everybody had access to care and we knew our population. So it was a great place to do research. Ben Kligler is now took over for Tracy and is leading that project. And the research is showing less polypharmacy, less dependence on opioids, more retention for the clinicians in the VA system, and better patient satisfaction. And and it was a change in the model of how we care for people. And it was really an opportunity to do more of a salutogenic evolution of, okay, let's put the veteran at the lead of their health mission, similar to a military mission, right? What do you need to be successful in a military mission? You need a team of caring people who will die for their country, right? They will die for their country. That's that meaning and purpose that comes from what do you want your health for? I want to walk my granddaughter down the aisle when she gets married, and I can't do that with this COPD. That influences my interest in stopping smoking. It's what brings meaning to our lives. And it was interesting. We got in, we went to over 50 VA clinics across the country, which is still happening. And we had fun and stimulating conversations with other clinicians within the VA, but we forgot one key ingredient. We forgot to train the veteran. And the veteran would be used to just coming to their doctor for, refills of their drugs. So we realized, but boy, we really need veteran leaders, just similar to a community leader. We need them to guide this and tell us what they need. And that was a really big teaching point, is who's in control of someone's health? You are. Jillian's in control of her health. I'm not in control of your health. I can help support it, but eventually each human being is responsible. And how do we create equity so each human being has the same potential to be healthy? And we got a long ways to go with that
Yeah,
goal.
yeah, for sure. It's so fascinating. I've seen patients kind of in my style for the last number of years now. I mean, probably since 2010, so last 15 years, I guess, and 11. And I can see my first visit, I have to really retrain patients because they come with like defenses up and they come with a story. They come with what their mission and their priorities are. And it's now become that I kind of wait and I just say, you don't need to say this is not a mental health issue. You don't need to say, you don't need to say like your pain is a 20 out of 10. I will believe you if you say it's a 10 out of 10. Like, so believing, it is amazing to me how much patients have, like, what they need has not been able to be addressed. And I've had multiple patients. In fact, I saw a new patient yesterday and said to her, it surprises me how many, like, when I say young women, I mean women into their 30s, but who come and say things like they've had doctors say to them, "Oh, you're too pretty to be this sick." And the patient I was talking to said, "Oh yeah, that was said to me. That was said to me. You just look way too good, to really be feeling what you're telling me you're feeling." And so I think that revolution and how we work with patients and how we as clinicians, the time that we have, what we're trained to do, and then this whole system is ready for a shift.
Yeah. Yeah, I mean, there's so many bits of truth in there is, right, who's in control of how they feel? We certainly aren't. Listening deeply is that deep listening is so important. I got a letter. When we started to do this at the VA, we also started to do it in our own clinic here at the University of Wisconsin. And so with the annual physicals, we started to ask, we're trying something new. Instead of going down your problem list,
Yeah.
I want to really focus on, what you want your health for, 5 years from now, and how can I help you achieve it? And I started doing that, and I got a letter from HR, and an attachment was a 2-page letter from a patient. And when you get a letter from HR, usually that's a bad thing. And the letter was 2 pages of, "Oh my god, I've never been asked this question before," and it was so meaningful to interact with the healthcare system to focus on what matters to me. 2 pages worth of how that positively influenced her perception of how we could use our skill set in service of her best outcome. So those are experiments that, if we're brave enough to not go against the system, because that usually fails, but slowly mold the system in a way that brings some of these new awarenesses into what we do every day. You started this podcast with saying this is just good medicine. On the first day of our integrative medicine fellowship, we said the goal of our job is to reduce the adjective to just good medicine, right? We don't need integrative, holistic, functional. There's all sorts of labels. What matters most is that salutogenic science, is how do we influence healthy outcomes within complex systems? And that's good medicine.
It's good medicine. And that's so satisfying. It's so satisfying to provide. I think it's we know it's so satisfying to receive.
Yeah.
So, can you talk to us a little bit about the word salutogenesis and like
Sure.
what that means and what that means
Yeah,
in this
but let me just go back quickly. What you just said was, "Oh, it's so satisfying."
Yeah.
Yes, it is. And when you get to that magic place where you have that aha moment and the little hairs stand up on you touch some beauty somewhere. And my God, if I have one experience like that every 3 months, I am so happy to be doing this work, right? If I can create an environment where I have that experience, God, every week or even every other day, how can we create an environment that does that day after day, while we also do the other stuff, right? One of my favorite titles of a book that I've never read is After Enlightenment, the Laundry.
This
We gotta do the laundry, right? So this isn't all gonna be those times where the hair stands up on your end. There's gonna be tough times where in the inbox in primary care is the challenge. It just keeps coming, right? And we keep, and through all that talk, I forgot your question.
It's so satisfying. It's so we were talking about that piece. The question was before that was about salutogenesis.
Yeah, yeah, thank you.
Find that
I love that word because it's the opposite of pathogenesis. So pathos is suffering and disease. So pathogenesis, which is greater than 90% of our medical education, is really focusing on disease and suffering, which is a good thing for us to focus on. What's the source of disease and suffering and how can we reverse it or overcome it? But the majority of chronic diseases we see, if they go on long enough, they're irreversible. So we really have to catch this upstream to really honor the power of the self-healing potential of the human body, which is dramatic if we catch it early enough. So we really have to work upstream, and that requires the opposite. Salute is health in Italian, salud is health in Spanish, and Aaron Antonovsky coined this term in the 1950s. He was an Israeli-American social scientist who studied survivors of the Jewish concentration camps, particularly women, and he looked at women who came through that atrocity with some resiliency. And he looked to see what was it in that turbulent stream of life that allowed humans to swim well. That's a paraphrase of his. What is it that helps humans swim well within the turbulent rivers of life? And he came up with this sense of coherence, that if I have meaning outside of myself to support this greater mystery. And what he showed in these women who got through the Jewish concentration camps is they had a mission to support others to get through that atrocity. And when they brought that mission out of their own self into others, they helped themselves. And that's compassion. Right? Compassion is two people suffering together. And when you get into that compassionate interaction, you lose yourself. You lose Dave, the ego. You lose Jillian, the ego. And it becomes this Jillian Dave
yeah.
unified process that really, I know this sounds fluffy, but it's so true in the science of what is. Everything is interrelated. Everything that alive is interrelated. And when we go into that space of that two-way causality of being human together, that never feels draining. So you can have empathy fatigue, because empathy by definition is I feel your suffering and I got to do something about it. I got to fix your suffering. I can't fix your suffering. Compassion is a little bit different. We agree to come into a mutual place together where we become almost one. And in doing that, I understand the reason for your suffering. It doesn't mean it's beautiful. What's beautiful is I understand how to get through it through sharing that empathy, but not having the expectation that I'm going to fix you. I'm going to join hands with you and walk to a different place together. When I realized that, it made my quality of life so much better, because you can't fix people when you can, right? Oh, I love doing that when we can. Nursemaid's elbow, probably the most rewarding thing. A kid comes in crying and I just twist their wrist and it's cured. Oh, it's so rewarding. And I can see the addiction of surgery where you take out someone's appendix. But in this work, those rewards generally are not as immediate.
Yeah.
So we have to practice this compassion for ourselves and for others. And if you do compassion right, it's never fatigue. There is no such thing as compassion fatigue. There is such thing as empathy fatigue, because by definition, empathy means I need to do something about it. Compassion means we walk towards a similar goal together and we become this united entity. And that's what I love about continuous trusting relationships in primary care. My friends pay me to be their friend. It's the best job in the world, you know? So I think that's a really important piece to make, the difference between empathy and compassion. And that's at the root of salutogenic science. So salutogenic science means how do we put our science towards the outcomes we want for each other and our communities? And that's to need less things. And when we need things, thank God we have health systems with the experts that can provide it. We need both. Right now, it's way out of balance. We have this much investment in pathogenesis and this much investment in salutogenesis. Even if we increase this 5%, if we went, and this is the research in primary care, 5 cents of every healthcare dollar goes to primary care. When you ask the public, they think 50 cents on every dollar, but in actuality, it's 5 cents. If we increase that to a dime, from a nickel to a dime, where 10 cents of every dollar went to trusting human relationships, that results in a 5-fold return on investment by reducing unnecessary emergency room visits and urgent care visits and hospitalizations. So that's the science of salutogenesis. How do we look at those financial models if we all agree that healthy outcomes are something we should all be working towards? We haven't agreed to that. We have not, as a society, agreed that everybody should be working towards healthy outcomes. We call it health systems, but they're really disease systems. And so we have an opportunity to change that intent if we all agree to, which is going to take some work.
And you're exactly right. You said very early in this show today that something that Jeff Bland says often, which is that you can't put a cost savings on disease that doesn't happen. So we don't know how good things could be if we really did this.
And the challenge is that's not in anybody's awareness. So the politician doesn't get elected.
Right.
But there's so much truth to that statement from Jeff but that's the outcome we want, right?
Yeah.
So,
Yeah.
let's do the right thing.
Yeah. So do you have any kind of ideas about so, we have people who listen to this show and we have a lot of, educated people and activated people. The patients that I see, nobody comes into my clinic. By the time people are seeing me, they have tried every diet, every exercise, every meditation, and they're still like something is still not right. And so, we have a very activated patient population, a very activated audience. So I'm just curious, if you were to send people on a mission to help make that shift or be part of that shift, how would you advise people?
Let me talk locally and then globally. What
Okay.
should we start with first? Let me start globally. I just asked to consult with Ontario, Canada, because they're investing billions of dollars to make sure every citizen in Ontario has access to a community clinic that has these trusted relationships. If we look at the country of Costa Rica, they did that for every province within Costa Rica, and their health savings through reducing inappropriate care through emergency visits. Oh, I wish I could remember the exact, but it was unbelievable. It was like 5-fold. I remember it being similar to the increased investment for primary care investment. So we have great models already to show that we can work more upstream into communities instead of just focusing on the quaternary care. I like to use religious metaphors. Cathedral on the top of the hill. We need that, but we need to shift the focus and the resources to the community. So that's the global, and that requires those policy leaders to really help us do that locally. All right, let's talk about local. And this is more of a challenge because it's so much based on people's context. The thing that I think people miss out the most is the importance of that mind body, if you will. For the only reason we say mind body is to make it easy for us humans to comprehend. There is no mind body, right? It's all interconnected. But so often, and one of my favorite quotes is by Henry Maudsley. He said, "The sorrow that hath no vent in tears may make other organs weep. The sorrow that hath no vent in tears may make other organs weep." So often, if people don't pause and self-reflect about what's going on in their lives, they miss the teaching message of a symptom. And that symptom might be low back pain. And the evidence supports this, that the main predictor of chronic low back pain is not disc impingement, it's your emotional state, more anxiety and depression. So people often want to go for the supplement or the drug. They always want that easy fix to get back to the person they were before. And so when someone starts out, let's say we have healthy Sally A, and Sally gets breast cancer. Let's just making things up. And Sally wants to get back to Sally A. That will never happen because Sally had breast cancer, right? That experience is changing Sally forever. So she's going to be Sally C. And that awareness brings us into a different consciousness, usually wiser, hopefully still alive, hopefully in a way that has a team of people who can continue to help prevent secondary recurrence. But everybody always wants to get back to Sally A. And everybody wants the quick fix. That old saying of people don't resist change as much as they resist being changed. But it's the self-reflection and the importance of awareness to change that I feel is usually at the root of what someone needs to really be ready to heal. And that old saying of when the body's ready to heal, the healer will present themselves. When the learner's ready to learn, the teacher will present themselves. And we need to get people ready for that self-reflection into what's going on in my life now. Could that be related to the symptoms I'm experiencing? And how do I use my awareness to choose to do things differently in the future? That's what the whole health model does with the VA by asking those deeper questions and using mindfulness training to clear the clutter. Mindfulness, by definition, is being in the present moment on purpose without judgment. The hardest part is the judgment piece, right?
This is okay. So things are coming to my mind. So this is so fascinating because I have thought for a long time, what is the difference between like what I did in primary care and kind of what I'm doing in this functional medicine Ayurveda private practice? And I think you're exactly right that the shift is really like, does it impact or like ripple through your nervous system, which is what Bob Navio would talk about with mitochondria and cell danger response. And so there are ways like if Sally A has pink eye and you just need like a little ribbon of erythromycin or a drop, then Sally A will come back after the pink eye. And so there are many things in our health system where we are looking to return just to who we were. You have one UTI, you get one prescription of Macrobid, you go right back to who you were.
Yes.
Because it doesn't really ripple through your nervous system necessarily as a distress. But if there is any condition which touches that nervous system, like you have 25 UTIs, or the pink eye won't go away, or now it's both eyes, or now it's affecting your vision, or there's some other thing going on with your eyes, then we need a human being to be with you. That distress, that nervous system, because those mitochondria have now shifted their energy production patterns. We now have an immune response, a safety versus threat. And so there are things in medicine, like a routine colonoscopy, like a routine mammogram for some, that may not impact that nervous system. If you have a florid family history of breast cancer, then every mammogram may ripple through your system and you may need that contact.
Beautifully said. The thing I love, sorry, I
No,
interrupted.
go ahead.
The thing I love about that is what you're describing there is the difference between transactional and transformational care.
Yes.
So transactional care is the pink eye.
Yeah.
I don't, after going to school, I don't know, 14 years or something like that, I I love seeing your pink eye because it gives me more time to talk about life and how are the kids and the grandkids, but I don't need to be seeing that pink eye. That's something that Google Clinic can do. Ideally, we'd do it through a trusted relationship with a healthcare team, but that's something AI can do. as
Yeah.
well.
Yeah.
And what you're talking about is that deeper shift is transformational care. That's what the breast cancer does differently than the conjunctivitis. And there's a quote I love that I think really summarizes what you just talked about, Jillian. And
Mhm.
it's a formula for trust. Trust equals competency times intimacy divided by degree of risk. So let's break that down. Competency means you went to school. You have some competency to do this job well. You went through the functional medicine training, you have that insight and that expertise. Intimacy means that you're able to use your emotional intelligence to build trust and compassion with another human being because they have to trust you in order to do what you're guiding them to do. And then that's divided by degree of risk. And that's the difference between breast cancer and conjunctivitis. When I have something that I could die from, that competency and intimacy become more important. And if you have the most competent oncologist in the world who isn't good at building your trust, you should find someone differently. If you have a really good, compassionate oncologist who didn't go to school and doesn't know their stuff, you should look for another oncologist. So it's really the combination of those two things based on your degree of risk. The higher the risk, the more we need that transformational care with people who care about us, who have been trained well to give us the best evidence-based care possible.
Absolutely. I did a talk for functional medicine in 2020, and it was talking about connection as what was it? It was like the idea was it was with Michael Stone. He and I shared the talk, and it was something about connection as a like a safety net against chronic illness. And one of the quotes that I had found was really about how when we're infants, everything that allows us to survive requires connection. And infants don't really, our frontal lobes don't really develop until about 6 months, right? So, like, as infants, we don't have like this executive function of I'm a person, I've got arms, I've got legs, we are infants. And so everything we need food, we need warmth, we need safety, we need attention. All of that is relationship based. And some of the most grim research I would say in the world was on the Romanian orphanages in
Mm,
the 70s, where there were two, they outlawed birth control and women weren't allowed to have birth control unless they'd birthed 5 babies. And it
mm,
was the people couldn't afford to raise and feed their children, and they dropped them in orphanages. And there were these rows of cribs where, with food and with warmth, but there was no attention. And a lot of these children
mm,
died. A lot of these
mhm.
children were developmentally delayed. A lot of these children had, lifelong, I mean, children, some of them did fine. They had all those basic needs. But without that relationship, our brains don't develop. And based on how our early relationships and early connection, I think it really does determine so much of how our health is across our lifespan.
Yeah, it's the foundation, right? And
Yeah.
and it makes life more fun, right? That's what
It
creates the
does.
hair standing up, and it's the transformational care. Yeah, annually, there's a rating of how much AI is being used in medicine. Thing that jumped to the top was how AI can help address social isolation by becoming an AI friend, right?
Yes.
Because AI can be programmed pretty well to be compassionate. I don't know if a AI can ever be compassionate, but you know what I mean.
Yeah.
It
It can present compassion as
can
a
present compassion. It has software that reads facial expression, pupil dilation that will be able to read emotions pretty well. And that's might be a tool we use in the future for that connection or at least feeling less isolated. But what's that going to leave out? And I think that's the big research question that we're going to have to figure out down the road. What is it to be human together? And that's a tough one because AI is expanding so much. There's got to be something about DNA and red blood cells and flesh and that energetic interaction between two living things versus an inanimate object and a living.
Yes. Well, and one thing that you said earlier in this podcast also about cognitive diversity, the importance of being confronted by cognitive diversity, I think I had not thought about that before, but it feels elemental to me and my growth and my evolution as a human being that I'm continually confronted by things I don't understand or by
Yeah.
people's perspectives that I haven't seen or heard before. And so while my Instagram, I'm sure, has been trained, it feeds me things that are like funny and kind of support my view. Um, it is important that and it's part of why I love healthcare is because I'm continually confronted by ideas that I don't understand that I'm required to understand as part of my work.
Yeah. I think one of the most important ingredients of training learners in healthcare is that we're curious. Huh, I never thought of it that way. Tell me more. And that's the best way to approach something that threatens us. That old saying of, what can this difficult patient tell me about myself? Right? What triggers me? What triggers me are those things. Maybe I was brought up to really think against that. Huh. Instead of just triggering me, creating this conflict between two people of othering, tell me more. I'd like to learn more about, why you believe that.
Yeah.
And then I create awareness and I fill my own gaps. And then I expand my cognitive diversity versus narrowing it. Narrowing it means I know what I need to know and I don't need to know anything more. That I will, that's confirmation bias, right? I will read the study that confirms what I already believe. But the scientific method encourages us to conform to the science. So if the facts change, I change my opinion. That's the
Yes.
scientific method, right? But so many people have that confirmation bias that they just believe what they already believe. And then that narrows down our ability to help other human beings because we know more and more about less and less. And that's why I love being a super generalist because it encourages us to go into the complexity and learn new things with each patient.
Yes. Amazing. Well, we are coming to the end of our show. So, is there anything else that you'd like to add or any kind of concepts or directions or resources for folks that you feel like you should be known today?
There's one thing I like to share, and that comes from Dr. Frank, who was a psychoanalyst back, boy, in the early 1960s. And he said, every healing encounter has four ingredients. I'll just end with these four ingredients. Number one is an emotionally charged relationship with a caring human being, right? Emotionally charged means that's transformational, not transactional. Transactional doesn't matter who you see, right? But emotionally charged relationship means that you trust somebody. It's emotionally charged. Number two, a healing setting. I go to Jillian's clinic because I know she can help me get through tough times, right? That's a place I go to expect healing. Really important, like a hospital or a clinic. Number three, an explanation for one's symptoms, right? I like to use the example of the serotonin hypothesis, which has a lot of flaws. But if I say you're depressed because you have low serotonin and I have this drug that will increase your levels and you'll start feeling better in 2 weeks, wow. And now the research tells us it's not the drug, it's the ceremony and the ritual that has the biggest effect. So, an explanation that we both believe will help us transcend suffering. Number four, and probably the biggest thing, is a ritual, procedure, or plan that involves participation of both. So both the patient and you have belief in this, that you both believe will help you get to a better place. So you have to have that prescription where you tear it off and you have that plan. Maybe your plan is, hey, you need to forgive your ex-husband or your ex-wife. It's a little bit deeper. It's one thing that we need to do, but you both agree that that's important. And what the research has shown that if you have those four ingredients, whatever you prescribe will work better, whether it's acupuncture, a supplement, a drug, or forgiveness. If you have those foundational ingredients of any way to help another human being through that ritual and ceremony, whatever you prescribe will work better.
Amazing. Great. Thank you. Thank you. Thank you. And thank you for joining us today. I really appreciate having you on the show.
My pleasure. Nice connecting with you again.
Thank you. And we love that you've joined us today at home to discuss how to make our whole world medicine. We rise or fall together and are committed to sharing knowledge and insight that empower us and our communities towards greater health. Thank you for listening to the Nervata podcast for complex health, and we'll see you next time.